pattern of Weekly Huddle. We try to discuss a common scenario and try to discuss about the practical approach of dealing with the commonly dealt cases that we see in our day-to-day practice. One such case that I would like to discuss today is about obesity and its treatment. So this case which I have seen recently in my clinic, I would try to discuss this case, and to facilitate the discussion, I have asked my friends and colleagues to help me understand about how to manage this case. So we are joined by experts today. We have Dr. Jagdish, who is a consultant physician working at KIMS, Dr. Parthsarthi, who is a surgical gastroenterologist working at KIMS, Dr. Raghuram, who is my MBBS classmate and working as a consultant medical gastroenterologist at Continental Hospital. We also have Dr. Mujib, who is a consultant anesthetist, and we have other physicians. Dr. Radha, who has been a long follower of Huddle. She is a dietetics and nutrition specialist. So I will try to get their viewpoint and try to know about the how to manage this case, and somebody who has their questions or suggestions, please feel free to share your comments. I'm co-hosted by my colleague Dr. Anoop, who is currently outside India, so his network is of an issue. So I'll try to see how much I can get his inputs as well. This session, this case that I have seen in a recent past, this is a 50-year-old female who is presenting with gradually worsening breathlessness over the last 6 months. The breathlessness was interfering with her day-to-day activities as well, and she is able to just carry on her regular activities, and her activities significantly getting restricted because of the breathlessness. She recently had a hospitalization in a nearby. The diagnosis was an atrial fibrillation, which further precipitated her heart failure. She was admitted for 2 days. The atrial fibrillation was managed medically. She was cardioverted with amiodarone, and after that, she was discharged home. At the same time, she was diagnosed to be having these obesity, morbid obesity, and obesity-related issues. That is where she was advised to continue other therapies. She was diagnosed to be having an obstructive sleep apnea syndrome, for which she is using CPAP only recently, about 1 month back. Background medical history: she has diabetes, metabolic syndrome, so-called diabetes, and the recent heart failure with preserved ejection fraction. Because of the recent heart failure, hospitalization, precipitated atrial fibrillation, they came to me for a second opinion. And because of the persistent symptoms, which was all to me looked like obesity and obesity-related metabolic syndrome and its issues, the suggestions to lose her weight was done. And in the discussion came the suggestion of bariatric surgery, because that weight is significantly limiting her physical activity. And when she was referred to a bariatric surgeon or a surgical gastroenterologist, the discussion continued, and she was referred back to me to give a clearance for surgery. And when we looked at her vital parameters, vital parameters were reasonably okay. Her heart rate was 100 per minute, blood pressure was 130/85, saturations at room air were 88, respiratory rate was 20. Her weight was 104 with a height of 152 centimeter, which brings her BMI to 45. The essential lab parameters of complete blood picture, renal function test, and the liver function test were normal. And the ABG showed a PO2 of 50 and PO2 of 95 and PCO2 of 50. Saturations I already mentioned, it was 88 room air. ECG essentially was okay, some low voltage complexes, but no significant abnormalities worth mentioning. Echo showed normal sized left ventricular cavity, normal valves on the left side. Right side, she had severe pulmonary hypertension with an measured right ventricular systolic pressure of 88 millimeters of mercury. The RV function was preserved, so is LV function. And now this patient who has the morbid obesity with severe pulmonary hypertension, this obesity which is interfering with her day-to-day activities, symptomatic morbid obesity, who probably needs weight reduction to make her feel better. And how do we help this patient? So first question, now that a discussion of bariatric surgery has been done, can we clear this patient for surgery? And what are the anesthesia considerations for surgery? And if the patient is considered for surgery, how does the surgeon look at this case? And if surgery is considered to be high risk or a bit prohibitive, then what are the non surgical means? How can we take the help from the dietitian to modify her diet and help her lose weight? And if can medical gastroenterologist equally help in managing this case? And do pills do come into picture, where these are currently there are new drugs which are available which have been set to promote weight loss? What are their roles in these patients? How much can they benefit is the essence of discussion. So to get started, I'll first get started with my anesthesia friend and colleague, because we have already started with the discussion of surgery. So, from a cardiology point of view, because of the severe pulmonary hypertension, I will have to clear this patient for surgery with a high risk. I would suggest to avoid the surgery. But if I have to consider, because her weight is significantly bothering her condition, I would be clearing this patient with a high risk. So I would take comments from Dr. Mujib. As a anesthetist, if this patient was considered for surgery, I don't know whether Dr. Mujib is available. If not, I'll try to move forward. Dr. Mujib, are you there? I can't find him. No, so I believe Dr. Mujib left. I'll come back to him once he is available. So maybe before we consider for any interventions, because we have to first focus on non-medical therapies first, I will try to take opinion from Dr. Jagdish. Dr. Jagdish is a consultant physician. So, sir, if this patient comes to you, and before we discuss about surgery, because her surgery seems to be not simple and straightforward, how can we help her in a non-surgical means, and how can we help this patient lose some weight? How do you look at this patient, and what are the role of the newer drugs, the SGLT2 inhibitors and other drugs which help promote weight loss? Can you share your comments, sir?
Yeah, hi Pranit and hi everyone. I think you have put up a very fantastic case forward. Because the trickiest part is all of us know when we're dealing with the BMI of more than, see, BMI we categorize the grade 1, grade 2, grade 3. Of course, in an Indian scenario, the grades completely change. And if you're looking at a BMI of more than 40, it's completely come into morbid obesity, and definitely some intervention is needed. The challenge here is, should we wait? Should we not wait? Because as the patient already had landed up in a complication where she has come with an arrhythmia, you have to cardiovert with amiodarone. Now, definite intervention is something which we need to clearly think about. But my one more question is, if I go to the history, the patient has the similar complaints from 6 months, and I need to know since how long she has started using CPAP, because before getting into any surgical interventions, first and foremost thing, yeah, lifestyle modifications, along with that adding on some oral medications or injectables before any intervention. So if you look into the CPAP per se is one of the treatment modality for obstructive sleep apnea, which is going to reduce your diastolic blood pressures, as well as the possibility of coming down on the pulmonary arterial pressures also is there. So they say minimum usage of CPAP for 3 months is going to give us some results in terms of these parameters. So that's one thing which I am interested to know. Since how long did she start on using a CPAP? Apart
She's
from
been
that, yes,
using it for the last 1 month, sir.
1 month. So I think I still see one challenge is, can I wait in this case? Considering her risk, yeah, I will still be. It is like we are almost on the both sides. We can't take the absolute call on this case, because the pros and cons are there. If we wait for a couple of months, can I expect one more similar cardiac event to happen? Yes, I don't know. At the same time, can we go ahead with the surgery? Yes, it is definitely a high risk case, as you told, because there is significant CO2 retention, and patients what other parameters also appears to be very bad for an anesthetist to take over the case for a bariatric. So other parameters, apart from expecting CPAP to do some great things over a period of couple of months, yes, you actually rightly mentioned about the other few drugs which has come into the picture. I think I hope everyone should be knowing about semaglutide or Rybelsus, which have been approved by FDA in last year, 2021, and it has come to India in this Jan. They say that along with all the lifestyle modifications, which means that having a proper diet with multiple meals with small proportions, with caloric restriction, at the same time with significant physical activity, at least, as you know, 150 minutes a week, I that is going to help to some extent with an add-on of medication, which is semaglutide. Initially, to start up with, we use 3, 7, and 14. These are the oral daily doses what has been recommended. But a few studies say a significant weight loss is noticed in subcutaneous weekly dosages compared to the oral dosages. But still, we are expecting a further larger number of RCTs to come up. If at all we start, we need to wait and watch for 3 months to 6 months. They say the expected weight loss on for people who have been started on semaglutide, initially to start up with 3 mg and later on escalate the dosage to 7 mg over a period of 15 days to 1 month, and later on to escalate 14 mg per day. So these are the expected titrations of semaglutide. And all the studies so far they have done, the largest of the studies, around 6,000 plus patients, so they have noticed an average weight loss of 5.9% to 9% of the weight loss. So if this happens, it is still a considerable weight loss. So before taking the call on a bariatric surgery, as a physician, I can definitely recommend to wait. But it is a tricky thing, as there is already a cardiac event. We have to explain the same thing to the patient before taking for the surgery, give them an option: should we go for a surgery or can we wait? Because, as I told, using CPAP continuously for 3 months, using Rybelsus, that is semaglutide, orally, as well as some strict lifestyle modifications with the diet and physical activity, if it is going to bring a change. Because a couple of studies have mentioned, I think, coming to the weight loss, they have noticed in 3 months to 6 months, certain people have achieved 54.9% weight loss for more than 10% of the people, and more than 23% weight loss in around 15% of the people. So I think it is completely individualized. We can give a try for a period of 3 months at least to see what is the trend before going to a major procedure.
Sir, I have a follow-up question. You mentioned that patients who were using 3 to 6 months, they were in a position to lose close to 6 to 10% of weight loss.
Mm-hmm.
Whenever we talk about obesity, we also look at short-term and long-term. Most of the therapies, they do produce this short-term weight loss. Any idea or any data regarding long-term effect of how much can these patients sustain the reduced or the reduction in the weight earlier? How long can they sustain that reduction in weight?
Okay, so far the studies, particularly on this particular drug, which I meant to say semaglutide, it was only for 2 years. So there is a significant amount of people who maintained, at least 50% of the people who maintained a remission for a period of 2 years, coming to diabetes as well as weight loss. Again, as I told, drug is only partially helpful. A drug with a stringent adherence to the lifestyle modifications is what it is insisted in most of the treatment modalities. So I think a lot of people do expect this. Doctor, give me a magic pill. I'm not going to change my lifestyle, but I need everything to happen with one pill to be popped every day. This is some false expectations or unrealistic expectations from the patients. I think it is very, very important for a multidisciplinary approach when it comes to weight loss, that too a significant BMI of more than 40. I think it's too hard, but it's not impossible.
Sure, sir. Thank you for this comments. When we talk about lifestyle modification, yes, physical activity and diet comes as a major picture, and we cannot overemphasize the importance of diet in reducing the weight. We say that close to 20 to 30% will be contributed by physical activity, and some studies say almost 90% of our weight is contributed by what we eat. We are what we eat. So I'll try to take comments from Dr. Radha. Radha, madam, can you help us understand about what suggestions can we do to this patient? The importance of diet. I know this few minutes you cannot do justice, but as a gist, how do we counsel this patient, or what recommendations can we do to reduce her weight in this current situation?
Yeah, thank you so much for the opportunity. Thank you for including me in the discussion, Dr. Praneeth. I'll continue with what Dr. Jagdish has actually left. I was a part of this trial when they were doing in India about semaglutide. And of course, diet is a major part, which we did try a lot in these obese patients while they were taking these injectables. We followed them for 1 year, wherein I still continued to give them diet counseling with regard to their diet. And once 1 year the project got over, and then the diet counseling stopped, but and so they started getting it back. So during this course of kind of doing diet monitoring for these patients who were on semaglutide, the best possible method in dietetics what we use is we first do what is called as motivational interviewing. Yeah, these are all techniques which we use in the area of dietetics, wherein we create a positive attitude in them. The very fact that they have been putting on weight is that they're not able to control their level of eating, or maybe their appetite too. It could be different ways. There are some who have binge eating, there are some who eat in quantity. So you have to know what is wrong with them and whether they have actually tried weight loss previously. And if they have tried, where did they find it difficult? And then you address that difficulty and redo the whole thing with them. And such cases are dealt one-to-one. It's not about the general counseling which we do on a day-to-day basis in our OPs, but then here is a case where you need to spend time, guide them, and be with them, always trying to tell them where is their difficulty and what is the solution. Because diet is one thing that every part of the diet query has a solution. But that query should be raised and you should be willing to answer at that moment for them. So that is what is most important. And I've told this before and I'm telling again and again, I've been in this area of work for 30 years and nothing has changed actually. What is most important is continuous energy restriction. It's called CER. So you need to have energy restriction on a long term. That is the only way that weight reduction can be seen. In this case, physical activity is going to be minimal because she's not going to. So look into her diet pattern, correct what's possible so that that can be sustainable, and then implement it and slow. But then this is something that, you have to weigh against the benefits and the risks. If it is going to be risky with doing the diet, and bariatric surgery is going to really benefit on at that moment, I think the surgery would be a solution. Generally, for somebody like 45 BMI, the surgery is indicated primarily. So diet is a part, even after surgery, before surgery, and way too longer. So this is something. And then when you come to energy restrictions, you have to look about fat in an Indian scenario and carbs. If they are rice eaters, then I have to know what is the quantity. If they are Indians, I even kind of get to know the amount of oil that they use on an everyday. See, the recommendation is, people get zapped with me, but then that this is what is recommendation for all of us after 18 years of age. The fat is termed as fat, but then it comprises of visible and invisible fat. Invisible is within the food, so we're not going to talk about it. But visible, the recommendation is 3 teaspoons per day per person. 3 teaspoons is 15 ml as visible fat, whether it is ghee, whether it is oil as oil, or whether it is butter. Everything put together has to come within that 3 teaspoons, which means 450 ml for a month, which means that if you have a family of 5 people, then it is 2.5 liters per month, including all varieties of oil. If that can be controlled, then all of us are healthy. That is where we do not do in an Indian setup. Yes, carbohydrates, if it is roti, yes, but if it is joined with ghee, there is a difficulty. If it is rice, then it is the quantity which has to be truly told to them what that quantity means, which I'm saying. I cannot just say 1 cup and leave it there. I have to literally tell them what that 1 cup means. How do they measure at their household level? And of course, nothing to do with fruits and vegetables. If you can control these 2 things, I think everything falls in place. In a case like this, on a diet reduction, we target at least 2 grams per kg body weight of adjusted body weight of protein, because that's most essential while they are on a weight reduction diet. So these are all things which are in numbers. These numbers are converted into a diet plan and then provided after maybe spending half an hour to 45 minutes with that patient. I think that's what is my inputs for this patient.
Ma'am, whenever we talk about calorie restrictions or quantity restriction, the biggest problem which at least I can relate to is the problem with satiety. How do we take care of this satiety? Because when we reduce the calories or when we reduce the intake of food, there is a rebound hunger where patients or somebody can end up eating more than what is required, and it kind of breaks down the entire effort that we are putting in. So the balance between reducing the calories and the amount quantity of food and the satiety, how do we balance it out?
Yeah, see, this is one thing. There again, the same thing. Eat small and frequent meals is what they say, so that you are always satisfied with regard to your satiety. And general things say, supposing if you're taking lunch, we tell them that before you actually sit down to eat your lunch, half an hour before that, eat a bowl of salads. But India is a country where people are not really encouraging to enjoy their salads. So they don't like it. So you have to create variety in that. Tell them how these salads can be had before lunch. So it's not just about saying green vegetable salad and leave it like that on the menu plan, but you need to give kind of a guidance to how this can be done in various forms to prevent monotony. That could be one. And another strategy that we generally do is, people on the Google read and then come back to me and say, chia seeds, madam, chia seeds. We take that, we still are not losing weight. Chia seeds are claimed on Google that it's a protein source. But if you really break down that, see, 1 teaspoon of chia seeds gives 0.1 gram of protein. And that 1 teaspoon of chia seeds, you soak it in a glass of water and it will swell to fill your stomach. So you're actually getting only 0.1. So it's not a protein source, but it is something that you can use in such patients to drink it with buttermilk before having their meal. Because what happens is, When you soak it in water or buttermilk for a half an hour, it swells. And you drink it along and drink another glass of water or another glass of buttermilk, it swells further to create fullness. So this is another thing that you can actually give. This can be done with some flavoring also. Sometimes I ask them to add a drop of natural vanilla to the buttermilk instead of salt. So such innovative ideas can be given to make it possible. Or sometimes they enjoy eating fruits as a salad. It's like a fruit salad, fresh fruits before lunch. So they eat that, and then we ask them to. Of course, there is restrictions to what kind of fruits they can have, but then we do make a difference. Yeah, so this is what we generally can tell. And of course, they have to put the rice or put the carb onto the plate with one serving. Eat more vegetable because it has to be prepared with minimum amount of oil. They can eat good amount of dal. And dal has to change in terms of having a whole dal instead of just having a split dal, because that's again fiber and that helps you fill. And then you can have your curd, but then tell them that you have your curd as a raita instead of having it like a bundi raita, which again they will ask me. I tell them you can add vegetables to eat. So these are all the fillers that you can see. All said and done, fruits and vegetables are free, or they can be eaten in unlimited quantities. So you have to do the innovation in trying to create some kind of newness with the you have to play around with your fruits and vegetables. That's what I do every day. Yeah.
Yes, ma'am.
Yeah, that's it.
Yes, ma'am.
You
Thank
can
you for
you
that.
can actually
Yeah.
make a smoothie also with your chia seeds. Add a few pumpkin seeds. They're not going to be really pumpkin seeds or sunflower seeds or two almonds, one date, and then give it a filler like a chia seed, and that will really fill your stomach. As in to have it half an hour before the lunch and then have lunch. So such ideas can be created, but the baseline is the dietitian needs to know all this, and she needs to have patience in counseling that patient. Patience is the most important requirement when you do counseling for such patients.
Point
Yeah.
taken, madam.
Yeah.
Point taken. With the
Yeah.
busy practice that we have, where spending time it becomes difficult, and that is where the role of dietitian always comes into picture. And yes, this cannot be underestimated. Thank you for your comments, ma'am. As you rightly pointed it out, for a BMI of 45, no matter whatever lifestyle modification that we are talking about, drugs that we are talking about, for the initial benefit for this patient, any significant weight loss that we have to achieve can only be achieved with bariatric surgery. And as you rightly said, it is indicated. And the only question is about the surgical fitness of this patient. But just because we have to consider this as a high risk patient, now if from the surgical standpoint, now there are so many techniques again which have come into picture. Which technique scores over other, and how do we approach these cases? I will try to take comments from Dr. Parsardi. Sir, can you help us explain the various surgical techniques, which one to choose, when to choose, and how do you look at this patient in terms of the surgical fitness and your concerns, sir?
Hi, Praneeth. Can you hear me? Hello?
Audible, sir.
Yeah. Hi, Jagdish.
Hi, sir. Hi.
Everyone. I'm talking in the car, so there might be some disturbance, but I hope my voice is clear over the Bluetooth. See, this patient,
Yes,
if I
sir.
understand, has got recurrent cardiac failure, high BMI, and also OSA. Correct? So
Yes, sir.
she will definitely be a very high risk candidate for any procedure, and bariatric surgery definitely comes under a complex procedure for her. So coming to what surgical options we have for her, generally we divide the bariatric procedures into restrictive and malabsorptive and combined. In this patient, there is an argument for and against both of these procedures. The advantage of doing a restrictive operation is it's a simpler operation. it doesn't change your physiology much or the anatomy much. The morbidity is lesser. It's shorter operative times, lesser complications, quicker recovery. But the flip side of a restrictive operation is the amount of weight loss which you can achieve may not be very robust. On the other hand, a combined or a malabsorptive procedure might take longer time to do, might have more complications, especially in the perioperative period. But the type of diabetic metabolic control you get through that is very robust. So in this patient, you will have to weigh the pros and cons of choosing one over the other. Would you want to go for a low risk and relatively lower yield procedure, or a high risk but a robust procedure which is going to last for long and achieve good metabolic control of our other obesity related complications? So prior to all of this, what we need to look at is whichever procedure you decide to do, the anesthesia is going to be general anesthesia, and the complications are going to be more or less similar in majority of the systems. So you need a good amount of prehabilitation you need to do. So the most two crucial things which already Dr. Jagdish and Dr. Radha have touched upon, the perioperative nutritional management, and also the diabetic control and the management of OSA. Their importance cannot be overemphasized. They go a long way in improving your surgical outcomes, decreasing your perioperative morbidity, and also if you have a patient whose prehab is really good, you will be able to assess their long-term outcomes and even decide your procedure based on that. You might, a patient who is really motivated and has done very well during the prehab period might be a candidate for a much higher procedure than what you actually anticipated. But given this patient scenario, I think she is definitely a very high risk candidate. One bridge procedure which we can consider in this patient prior to bariatric surgery is a gastric balloon, which is a very low morbidity procedure. It is done in the outpatient, and this can go a long way in achieving preoperative weight loss, control of OSA, and also make her surgical risk better. So my first option in this patient would be to consider a gastric balloon. And then once all the measures have fallen in place and the patient is sufficiently optimized, we can then decide upon what is the definitive surgery we want to go for her. The two most common and popular options in bariatric surgery for these patients are, one is the laparoscopic sleeve gastrectomy, and the second one is a Roux-en-Y gastric bypass. So the traditional conventional philosophy is, if you have a very high risk patient, do a simpler procedure like a laparoscopic sleeve gastrectomy first. It's a very short procedure. It can be completed in 45 minutes to 1 hour. And the morbidity also is very less. The malabsorptive problems which can arise in the other problems are avoided here. And this way you can convert a very high risk morbidly obese patient to a much manageable obese patient. If the patient has not achieved good control of her metabolic syndromes or has not achieved a good weight loss only with the laparoscopic sleeve gastrectomy, you also have an option of going in later again and converting this sleeve into a malabsorptive procedure like a Roux-en-Y bypass a couple of years later when the patient is a better surgical risk patient. So my approach in this patient would be go for a balloon along with the other measures and then reassess her. And I would have a bias towards doing a sleeve gastrectomy in her and then see how she performs. And then later, if needed, we can go for a Roux-en-Y gastric bypass when she has achieved a good amount of weight loss and metabolic control. You want to ask or add something, Praneeth, Jagdish?
No, sir. That was quite elaborative. You told about being restrictive, malabsorptive, and the way how you approach depending on the surgical risk of the patient and how simple short term versus long term. It was quite elaborative, sir. I'll get back to you, sir.
Yeah, thanks.
Yes, sir. So you mentioned about the gastric balloon.
Yeah.
So I will take comments from Dr. Raghuram. Raghu, can you tell us about this gastric balloon? I believe it is done by medical gastroenterologist, and what are the indications of this patient? Who is an ideal candidate? How effective is this, and particularly in relation to the given patient?
Yeah. Hello, everyone. Um, so I agree with Dr. Padsarthi that if we are looking for a significant amount of weight loss, although not a very significant to the tune that she comes out of the obesity grading, but certainly to make things better, reduce the chances of any further cardiac events and achieving a meaningful weight loss. Uh, and considering the anesthesia associated risks being very high in her, if we aim for a brief procedure which can achieve a reasonable amount of weight loss, then among the options, in addition to the dietary and medical regimen, I would say that intragastric balloon is certainly the only option for her. Now, when we say intragastric balloon, we need to understand that the balloon can be kept in place for 6 months, and in some cases, we may prolong that further to 9 months. The obvious problems with prolonging the balloon placement for more than 9 months would be the balloon may rupture, and once it ruptures, there is a high risk of it migrating into the intestines and leading to bowel obstruction. So that would create another further new issue in her. So we don't want that. And ideally, 6 months, we can safely say that the risk of rupture of the balloon is less. Coming to the complexity of procedure or the anesthesia that would be required, duration usually it would take around 10 to 15 minutes to complete the procedure. Anesthesia, we can go for a conscious sedation, and only to the extent that she can tolerate. A deep level of anesthesia may not be required. Um, then, yeah, we pass the catheter with the deflated balloon attached to the tip. Under endoscopic guidance, we confirm that the tip of the balloon is in the stomach, and then we inflate the balloon with saline, which is mixed with methylene glue. The usual volumes, we start with around 400 to 500 ml, and slowly we can increase the amount of saline based on the weight loss that is achieved. In case we see that the desired weight loss is not being achieved, we can always increase the amount of saline. And essentially, this works as a restrictive strategy where we are reducing the capacity of the stomach. So procedure-wise, duration, I've already talked about that. Usually 10 to 15 minutes, a quick procedure without deep anesthesia requirement. Then the usual problems that we see with the intragastric balloon is that if the patient is not motivated enough, once we place the balloon, the initial 4 to 5 days or say 1 week is going to be very tough on the patient. Suddenly they realize that the gastric capacity has gone down, and once we initiate oral feeds, there are high chances that they have recurrent vomitings and associated dehydration. We have seen people going into pre-renal AKI as well. So, and most people find it difficult to adapt to the new change in the thing, which is the new norm for them. And some people who are not motivated enough, they may ask or coax us to remove the balloon within 2 or 3 days. So these are the usual problems. So the patient needs to be explained in detail what all is expected after the balloon is placed. And obviously, we need to look into the problems with electrolyte abnormalities and AKI in some situations. So post balloon placement, we may have to hospitalize them for a brief period if the problems with vomiting and renal issues arise. Coming to the amount of weight loss that we can expect. Now, whenever we are talking about bariatric procedures or the expected weight loss, we talk in terms of the excess body weight and the percentage of weight loss that can be expected in this excess body weight. So the surgical options, obviously, they are the ideal things if there are no contraindications, and we can expect around 60 to 70% of loss in the excess body weight with the surgical procedures, be it sleeve gastrectomy or the malabsorptive procedures like Roux-en-Y gastric bypass. But when we talk about the intragastric balloon, the amount of excess weight loss that can be expected is only 30%, right? So that's the obvious limitation. And we understand that the balloon is going to be in place for only 6 to 9 months. And after that period, once we remove the balloon, most people, they tend to gain the weight that they have lost in this interim phase of 6 to 9 months. So that is the usual problem with intragastric balloon. And that's the reason even Dr. Pardha mentioned that we need to use this as an interim procedure to improve her clinical condition and make her fit for a definitive surgical procedure. Yeah, so if we talk about the amount of people who are able to maintain that weight loss that they have achieved in the 6 to 9 months phase, so various trials show that only 20 to 25% of people are able to maintain that weight loss, which has been achieved in this 6 to 9 months. And the remaining 75%, they tend to gain the weight that they have shed in these 6 to 9 months. So that's the obvious limitation with intragastric balloon. Yeah. So think I have addressed most of the issues. Yeah, endoscopic procedures, if we talk about other options, there's an option of endoscopic sleeve gastroplasty. There again, the amount of weight loss that we can expect is to the tune of 40 to 50% excess body weight, the percentage of weight loss. We can expect around 40 to 50% of excess body weight loss. But the problem with ESG is the long-term results are not available. This is something which is of a recent advancement. And what has been seen is after 1 year, the sutures that have been used to stitch the stomach and reduce the capacity of the stomach, they can give away. And the weight loss that has been achieved, that benefit may be lost over a period of time. But we need to look for and wait for the long-term results with endoscopic sleeve gastroplasty. Yeah. Over to you, Pranay.
Yeah, Raghu, because anesthesia is of a concern for this patient in terms of severe pulmonary hypertension.
Yeah.
Now, this gastric balloon obviously seems to be an attractive option because there is no need for anesthesia. You said only some sedation, short duration procedure. So this looks attractive. The only caveat being it is short-term benefits. Probably we do this and hopefully patient drops some weight, and maybe if her pulmonary hypertension is all attributed to her obesity, with a drop in pulmonary hypertension, if she becomes a more surgically fit candidate, we may opt for surgery. This is what I could understand. Now, from the practical aspect of it, how affordable is this procedure, or how much expensive is this procedure in terms of, because it's offering short-term benefit? How much do you think is it going to cost to the patient?
Yeah. So the balloon cost is certainly prohibitive, I would say. The MRP is around 1.3 lakhs, and yeah, so that is one obvious problem with the balloon placement. But yeah, if we narrow down on the possibilities and if the options are limited, then we have to go ahead with this thing.
The balloon that has been placed after 6 months, how do we retrieve it?
So we go in with the endoscope, aspirate the whole fluid that has been injected into the balloon, and once the balloon is deflated, it is removed perorally.
And this procedure, I believe, is again done under some sedation and probably does not require anesthesia.
Yeah, mild sedation should be good enough for that.
Good. You mentioned about endoscopic sleeve gastrectomy as another option. Again, because we are talking in terms of anesthesia, what sort of anesthesia are we expecting when we are talking about endoscopic sleeve gastroplasty, if I sounded correctly?
It is endoscopic sleeve gastroplasty. And yeah, anesthesia again is going to be a problem if we are talking in the context of the current case, because the procedure duration of the procedure is at least 1 to 1.5 hours. In some situations, it may take even longer. And obviously, once there is a contraindication for any kind of bariatric surgery, it becomes a contraindication, especially from the anesthesia perspective, for ESG as well.
So looks like with the current situation that we are looking at, probably the balloon seems to be the kind of a relatively safe option, but it seems to be a bit expensive in comparison. Now we understand that bariatric surgery seems to be a better therapy in offering her significant weight loss or a more reliable and consistent weight loss. But equally, there are concerns about the long-term effects of bariatric surgery, and equally the long-term efficacy of bariatric surgery, where patients who underwent bariatric surgery, they again gain their weight back. Can you throw a light on these particular issues, both in terms of long-term safety and long-term efficacy?
So when we talk about surgical procedures, restrictive surgeries, the amount of weight loss that is achieved is to the tune of 60 to 70%. The excess weight that is there and the percentage of weight loss that can be expected. But then whatever weight loss has been achieved, that tends to stay, particularly with the bariatric surgeries. The other group where malabsorptive strategies are adopted, like Roux-en-Y gastric bypass, there again, the weight loss is the maximum amount of weight loss that is achieved to the tune of almost 60 to 70%. And this weight loss is also a sustained one. I don't see any reason why people should gain weight after undergoing one of these procedures. And if there is a chance of failure, that possibility is there with the sleeve gastrectomy, because over a period of time, some of them, the stomach capacity and volume tends to increase over a period of few years, and that again may lead to some amount of weight gain. But usually, the amount of weight loss that is achieved with the surgical options, that tends to remain, and we can achieve a long-term benefit with the surgical procedures. With ESG, the endoscopic sleeve gastroplasty, yeah, we need to look for the long-term results. This is a new procedure, new innovation on the horizon. So The obvious concerns here are it has been seen that the sutures give away after a period of 1 or 2 years, and the weight loss may not be a sustained one.
Raghu, about the long-term side effects, particularly with the malabsorptions and the malabsorptive type of bypass.
Yeah. So with the malabsorptive ones, obviously vitamin deficiencies are an expected thing, and we need to keep a close watch regarding the vitamin deficiencies and also the protein energy malnutrition. Okay. And in case we see deficiencies of vitamin, we need to treat them aggressively. But whenever a malabsorptive surgery is done, vitamin supplementation is done as a rule. And periodic monitoring also comes hand in hand with these kind of surgeries.
Yeah, so we end up treating most of the diseases like the treatment itself can be a disease like for autoimmune. We may give steroids for pediatric malabsorption, for coronary artery disease, antiplatelets. So I think it is the balance that we probably have to do. And I think in these patients also the weight and its related issues and probably the long-term issues, I think must be balanced and patient should be counseled and the decision should be taken. I think I had my questions answered. I'll open the forum for discussion if anybody has any questions or comments. Can see I see Dr. Mujib joining. Thank you, Dr. Mujib. We were missing your comments. I hope you were following the discussion that was happening. The whole essence of bringing up this discussion was about the risk of anesthesia for surgery and be it endoscopic procedure. Can you share your comments on, as an anesthetist, about these cases for a patient who has morbid obesity with severe pulmonary hypertension who needs some bariatric surgery or weight loss therapy? How do you look at these cases and what are the challenges that you would be facing in this patient?
Hello, good evening, everyone. So this is the case of this obesity patient with pulmonary hypertension, sir. Are you hearing? Are you able to hear?
Yes. Please go ahead.
So this severe pulmonary hypertension patient. This and Partha sir told about this lab surgical options, and Raghu sir told about this medical options. In the medical options also they want some conscious sedation. So in that case also the risk is same as general anesthesia. So in the conscious sedation also the patient is awake, but chance of aspiration and chance of sudden stoppage of breathing also is there. So they are so sensitive to the anxiolytics and the sedative drugs. So mostly the medical gastro side also this risk is high as surgical high same. And the intraoperative also. So these patients have pulmonary hypertension. So chance of right heart failure is there. So chance of pulmonary edema also there in the same side. And the intraop also. So chance of difficult intubation, difficult mask ventilation also there. So mostly the obese patients are neck circumference is high, as much so 47 inches is the parameter. So if it is high, that the chance of intubation is high, and these patients have the obesity surgery mortality risk satisfaction score is there. So before taking every patient have to stratify. So this includes the BMI and gender of the patient and age of the patient more than 45 and hypertension and some risk factors, the chance for embolism like previous chance of VT and vena patient having this pulmonary hypertension. The all includes one. Hello, are you able to hear, sir?
Yes, we are able to follow you.
Yes, sir. So the risk of mortality, each parameter contains one point contains, and they're divided into class A, class B, class C. So 0 to 1 points is mortality is as much as 0.2 to 0.3%, and class B is 2 to 3 points. that is 1.5% risk is their mortality, and class C is 4 to 5 points, that is 2.5% mortality risk is there. So we have to stratify the before taking the for the medical and the surgical options. And post in the introp also, and these for surgical procedures, so positioning is little bit so positioning is so important. So chance of nerve injury and chance of rhabdomyolysis is also there. So proper positioning and proper cushioning also have to put and standard monitoring have to get, and usually we put NIBP will put. So these patients' arm is a little bit high. We have to put intraoperative, this one intra invasive arterial have to monitor, and the pre-op also have to be DVT prophylaxis have to kept. And that is hello.
Yeah, Dr. Mujib.
Yes,
We could hear you. So
yes,
any particular suggestion that you would be giving to the surgeon who is operating or the gastroenterologist who is performing, anything that they need to be mindful while they are doing, and any preference of one drug over other, and anything that other associated people involved, like a cardiologist or an endo, anything
usually,
that you would suggest?
yeah, the multidisciplinary approach you have to approach, and we have to include the cardiologist you told, and the pulmonology people also have to include. So before any obese patient coming for the surgical, so we do this one. Most of these patients are obstructive sleep apnea is there, so we'll do polysomnography. So in that, apnea hypopnea index is there. So before so based on that also, the risk is stratified. With apnea hypopnea index is more than 30, so chance of risk is high, and intraoperative and postoperative also, and morbidity mortality is high. And okay, sir.
Yeah. Thank you, Dr. Mujib. So I will take comments from Dr. Shankar sir. Shankar sir, you heard the discussion from the concerned specialist. As a physician who is practicing in a tier 2 city, I'm sure you will also be looking at most of the cases with morbid obesity, because obesity is kind of prevalent now, more in rural areas, so to speak now. So a case who approaches like this, how would you look at it? How would you look at bariatric surgery, and do you have anything else to add to the discussion that we already had? Over to you, Shankar sir.
Good evening to all. There's a nice discussion regarding this management of obesity. Since there is a high risk for the surgery, as a physician, I opt for only drug therapy, especially the choice of agent of obesity with or without diabetes. We have got injection semaglutide subcutaneously once in a week. We start with 0.25 milligrams once weekly for 4 weeks. Then the dose is increased to at 4-week intervals, the 0.5, 1 milligram, 1.7 and 2.4 is the maximum recommended dosage. So this is a very good approach where over a period of 1.5 years, actually here we need not wait for 1 year or 1.5 years, but there is a robust evidence that there is a loss, weight loss is very conspicuous. So because I don't have any experience regarding this injection semaglutide subcutaneously, but recently a patient came to me. She was my own patient, but she went abroad to join her husband in Gulf countries. So when she attended to me after 6 months, I surprised to see her. There is a lot of loss of weight, more than 20 kg weight loss is there over a period of 12 weeks to 24 weeks. So I have gone through her case sheet. then it was written injection semaglutide, the Rybelsus injection once a week subcutaneously. So with this, I can, I don't have experience with the semaglutide, but a patient who is on semaglutide written somewhere, but there is a drastic weight loss. So because this patient is here, the index case is a high surgical risk case where we can try this injection semaglutide, start with 0.25, then gradually over a period of once in 4 weeks, we can increase the dosage. Only drawback with this Rybelsus is patient sometimes may not tolerate because of nausea and vomiting. There we can reduce the dosage or we can continue the dose earlier. So this is regarding this injection semaglutide, the drug therapy in case of morbid obesity. And if the semaglutide is not available earlier, we used to give liraglutide. That is, we start with the 0.6 milligrams daily. Here, the drawback with the liraglutide is we have to give every week, every day. So 0.6 milligrams daily for 1 week, and at the same weekly intervals, we escalate the dosage of liraglutide, where there also the only side effects with the liraglutide are the same, nausea and vomiting. But recently, we have got a very good molecule. It has come into the market, is the Monjaro. That is dual acting GLP-1 and GIP receptor agonist. That is a gastric inhibitory polypeptide and the glucagon-like peptide 1 receptor antagonist. So there's a dual acting GLP-1 and the GIP. So this is a tirzepatide. So it is available in the market as the Monjaro. So here we give, this is also given as a once weekly subcutaneously, 5 milligrams, 10 milligrams, and 15 milligram dosages. So where over a period of 1 to 1.5 years, there is a drastic reduction of weight by 16 kg, 22 kg, and 24 kg respectively. So if tirzepatide patient can afford this tirzepatide, that is a Monjaro, I prescribe this tirzepatide in this patient to reduce her weight loss, to reduce her weight, so that all the complications related to the obesity will come down, and later we can we have to, at the same time, we have to follow the diet, physical activity, behavioral therapy, and if necessary, then we should think of. So other things, bridging along with the tirzepatide, if you want immediate results, then we can go for intragastric balloon, which is a non-surgical procedure. This is my opinion regarding this morbid obesity with multiple comorbidities and surgical risk. Intragastric balloon. Apart from that, the tirzepatide or semaglutide. Thank you, one and all.
Thank you, sir. The tirzepatide is something I think which is a new kid in the block. I have no experience in this, and I'm sure it's exciting that there are new molecules which are available, which can probably help these patients achieve their goals. Before I conclude, I will try to read the chats which are there. I think Anoop had few questions. He left. If we put target BMI for this patient as less than 35, it is very optimistic to believe GLP-1 receptor agonist or similar therapy will lead to such response. Only bariatric is consistently shown to be effective. Yes, we discussed about that. How reliable RVSP is to measure true PA systolic pressure, particularly in obese patients with poor echo window? Will right heart cath be routine in such patients to document true PA pressure before declaring this patient as high risk based on echo-derived PA pressure? So this question, there were studies where pulmonary hypertension is associated with obesity due to multifactorial reasons, and echo seems to be a reasonably reliable measure, and there is no definitive indication to do right heart cath. And when we are talking about right heart cath, again, these patients, we need to understand that for right heart cath patient needs to be on lying down position in cath lab. We can sometimes do bedside where we can float a PA catheter through internal jugular vein, but in Indian setup, it is a bit difficult. But to answer the question, it is not always needed to do right heart cath, but when can be done, it is a reliable measure. Any insights on endoscopic measure as a surrogate for bariatric surgery which doesn't require general anesthesia? I think Dr. Raghu answered this question. Anesthesia is still an issue for this patient because of the long duration of the procedure. And for laparoscopic surgery, general anesthesia may be prohibitive for this patient given high right-sided ventricular pressure. Yes, the point taken, and Dr. Mujib has also mentioned about the anesthesia-related issues. I think most of the questions are answered, and if there are any other questions or comments, I'll wait. Vijay,
No?
sir, you have anything
Yeah,
to
yeah.
add? Yes,
I'm
sir.
Dr. Vijay Kumar. Very good evening to all. I would like to add some more thing. Whatever the method you choose, whether it is pharmacological or surgical, lifestyle modification is the most important step. That's number one. Number two, regarding the GLP-1 agonist, this semaglutide, oral semaglutide is called Rybelsus. It reduces the maximum weight loss is only 5 kgs. The injectable form is called Wegovy, which is not available in India, which is to hit the Indian market by June next year. So the weight reduction with Wegovy is to the extent of 15 to 20% of the body weight. It's a remarkable. That's number two. So the intragastric balloon treatment is only still an experimental stage, and all the insurance companies says it is a investigational treatment, and there is no robust data for that. Regarding the two most important surgical options for the bariatric surgery, one is the sleeve gastrectomy, which has got less effective, less weight reduction, but at the same time, the complication rate is very less. Whereas RNY more effective, but the complication rate is more. And these are the things. And as one more thing I would like to add is as an interventional cardiologist is the embolization of the left gastric also is one of the modalities to reduce the weight. The mechanism is the ghrelin is the appetite hormone which is present in the fundus of the stomach. If you embolize the left gastric artery, there will be suppression of appetizing hormone ghrelin. So the appetite is decreased and there is a weight loss. Of course, it is very modest. This is also one of the way of treating embolization of the left gastric artery. Thank you.
Yeah, thank you so much, sir. I think that summarizes the entire session that we have discussed over the last 1 hour. I think you covered the entire aspect from pharmacology to the advanced therapies as well, including interventions. So we are 9:12. So with this, I will end the session. Thank you everyone who have joined, particularly my experts for sharing this comment. Weekly Huddle is a session that we host every Wednesday, 8 to 9 p.m. We will be coming with next topic another Wednesday. If you have any other topic which is of interest, if you think that we should discuss, please share with us. And until next time, thank you everyone for joining. Good evening and please take care. Thank you everyone.